And I feel like there's a higher level of expectation when things are recorded. So I definitely feeling a little pressure, but hopefully this is just exactly like as if I was standing there giving you this talk. Um, Definitely email me with any questions. I heard of the mansion on those streets. Sorry if I think I brought it up last year, but we don't do too much in DC. Basically, it's downtown in the capital area and just a lot of secret doors that my kids like a lot. The quote, still the same. We'll make candles so expensive only the rich will be able to afford them. So that's Thomas Edison saying how he'll actually make light bulbs and put the candle makers out of business, I guess. And so they'll be expensive because there won't be many candle makers. And then Arcane is still my favorite show. No disclosures at this time. The eosinophil, biology, some definitions. We'll talk about the history of hypereosinophilic syndrome, some organ manifestations, causes, then how would we evaluate HES, which I'm sure you guys know. Probably heard a lot. I remember in fellowship, I heard a lot about HES. So, and then evaluation and management. Eos is the goddess of dawn, dawn meaning like the morning, and you can imagine it's very red in the morning. So Eos was the name of a dye, and of course the eosinophil binds to Eos, which is why it's the eosinophil because it loves Eos. So basically, this goddess opens the gate for the sun and helps the sun get across. She usually has a crown and wings. For some reason, usually rose-colored hands, just because it's dawn. And she is responsible for pouring the dew in the morning. She's usually depicted as fragile or delicate, even though she's actually like one of the strongest gods, apparently, which I hadn't even heard of her until I was reading about eosinophils. But anyway, because she is actually very strong, I put it's a charcoal laden crystal there in her hand or near her hand. It's like a dagger. So she's pretty tough. There you have it. Of course, the eosinophil is red on an H&E stain because it's eosin. Is eosin, as you can see, it's mostly a negative molecule, and that's why it binds to the eosinophil. The eosinophil proteins tend to be positive. So we've got the major basic protein is positive, I believe. The cationic protein, of course, is positive, and those other ones. That's what's going on there. The charcoal-laden crystals. One of their key components is actually galectin 10. Galectin 10 is one of the most common proteins in the eosinophil, perhaps the fifth most common protein, and it's a vesicular transporter of the eosinophil granules. And this can result in extracellular traps. Trying to coin the term etosis. It came out after netosis, which we've all heard about by now, especially because of COVID. Netosis is happening in the ARDS of COVID. But basically, they wanted to say that a similar process is going on. Basically, the eosinophils, granules, they remain intact, but then the galectin and chromatin fibers polymerize uh, from multiple eosinophils, and so it can actually make this crystal that's, I believe, larger than a single cell, and it's basically a minefield. So that is what can result in the eosinophilic mucin that's super thick. Also, uh, the, like the Trantis Horner dots, at the eosinophilic debris there. So I thought that was an interesting take on it, but they're basically trying to ride the coattails of NETosis. So that's what eosinophils are going to do. They can create minefields, uh, create abscesses, microabscesses, which we'll get into. So you guys have heard, I'm sure, of IL-5, 3, and GM-CSF. These not only stimulate production, but they also delay apoptosis. Derived from the bone marrow, but it goes to the tissue, and actually it's a tissue residing cell. So the distribution of blood to tissue is 1 to 100. That's really important because what we're measuring is the blood level. So I've just got a, I'm not sure how this is going to show up with the animation. Sorry in advance, but if you were trying to look at how many boats are, in a lake, but all you can do is look at the traffic on the road, you're going to be kind of pretty far off. So you got to remember when you're doing a peripheral blood eosinophil count, that's sort of like looking at how many boats are on the road. But what you really want to know is how many boats are in a given lake. Um, Boats, if there's like hundreds of boats on the road, then something is up. But if there's only a few boats on the road, there still could be something up. So definitely high eosinophils are probably bad because they're going somewhere, but they might be involved in some processes, even if there's a normal eosinophil count. So it looks very peaceful. Definitions: hypereosinophilia, basically more than 1,500 eosinophils on 2 exams. Um, then you've got tissue hypereosinophilia, which is just higher percentage of eosinophils. Or the pathologist is of the opinion that the tissue infiltration by eosinophils is extensive. So really, that's where you could have a normal eosinophil count, but if you just have a tissue full of eosinophils, that's tissue hypereosinophilia. And then you might also just have a lot of eosinophil granule proteins in the absence of eosinophils also. That's C. Then hypereosinophilic syndrome, so that's essentially where you have both, the 1,500 and you've got the organ damage, and you've excluded other causes, which is kind of tricky because it gets into semantics. Then the last one, tissue restricted HES, kind of similar to the tissue hypereosinophilia, and sort of treated the same as well. I will say other papers, I'll quote these later, talk about severe hypereosinophilia as greater than 5,000. And actually, Amy Cleon says that's when you get a bone marrow biopsy. I'll cite that later on. Normal. I think when I was a fellow, for some reason, the eosinophil normal range was like 400, and then it like crept up to like 800. I think it's still there, but sometimes I see it at 500. It sort of depends on, I guess, where the lab is sending the CBCs. Is everyone else seeing that the range is different, all the time? Anyway, um, so if we look at the asthma guidelines, they specifically GINA, they don't actually say when we have eosinophilic asthma, but they cite studies that suggest a high eosinophil count is at 300. Let me pull that up, actually. Be clear, eosinophilia is so important that it's actually on one of these lists of risks for future exacerbation. So there it is, right alongside smoking, right alongside poor adherence, eosinophils are bad, and they're not talking about eosinophils of 1500. So, and basically they took 31 patients who were non-smokers. They were all asthmatics and allergic to dust mite, and all they did was look at how long till they had an exacerbation, which exacerbation was just like the need of steroids. It wasn't like a hospitalization or anything. And if they sorted the patients by eosinophil count, as you can see, in 1 year, basically 70% of people had had an exacerbation, versus in the low eosinophil count, almost no exacerbations. So really at about 3 or 400, that's when you can say this is a person with asthma who's going to have more frequent exacerbations. And I know it's, as far as I am aware, the FDA doesn't um, asthma. It's kind of just based on whatever the insurers will pay or things like that. I'd be interested in what recent conversations you guys have had about that, actually. So, about the history. Actually, if you read about hypereosinophilic syndrome, in 1975, this paper basically says it's almost 100% fatal at 3 years. So that's very much a paradigm shift from where we are now. Some of these patients didn't have that high of eosinophils, but most of them seem to actually have eosinophilic leukemia, like 20 to 30,000. Um, but some of them were not that high. So basically, they said hematologic and cardiovascular were the most common manifestations. And that's very different now. But I just wanted to point that out, and we'll talk about what the eosinophil can do to the heart, just because we should know that's like the worst case scenario. We should know what that it does. 9. This is a paper written by the NIH. It's just a review of like 188 patients. Yeah, I think, yeah, Princess, yeah, NIH. Okay, so basically they looked at what are these HES patients presenting with? And as you can tell, the most common thing they found was dermatologic manifestations, and cardiac was like 5%. So it's really a paradigm shift. Now, this second chart is they looked 1 year later at the patients and saw what manifestations. So still, dermatologic was the most common, but that bar is a lot higher. So I made it so the scale was the same. You can see the 40% lines up at the top. So now we've got 70% of people with dermatologic manifestations, and 20% with cardiac manifestations. I think it was like 8%. So what they were trying to say here is, you know, the symptoms you start with are not the symptoms like you end with. So people are going to have a bad case there. Yeah, but hopefully we're still going strong. So here's kind of a list of everything that eosinophil can do, which it can affect any system and it can kind of do anything. Um, this article kind of struck me as like pre-guideline material. Like as far as I know, there's no actual guidelines for HES, um, but this looked like it was a almost like a consensus statement review article sort of thing. I do want to point out now that eosinophilic myocarditis is there under other, so it's like cardiac manifestations didn't even get its own, topic, but we'll still talk about it here. Cardiac manifestations of eosinophils have basically been reported with all sorts of causes: HES, EGPA, eosinophilic leukemia, probably the most common. as as far as the eosinophilic myocarditis. Actually, you can have it just with GM-CSF administration, drug reactions such as stress and even parasite infections. So I'm going to talk about the risk factors, I guess. Um, it, Cardiac manifestations have been re- reported as low as just above 1,500, but in general, most of the patients had eosinophil counts much higher. But basically, higher B12, dysplastic eosinophils, because it's eosinophilic leukemia usually, thrombocytopenia and splenomegaly are kind of risk factors for the cardiac manifestations. Worth 1,000 words. We're going to talk about this. Basically, the eosinophil acutely can damage the myocardium. When that happens, it's going to expose, the tissue platelet activating factor, and that's going to cause clots. So then the clot is going to become a apical thrombus. Also, that can entrap the chordae tendineae, and so you're going to have mitral regurg. Then also, throughout the whole process, it's going to cause fibrosis. So even after, like, I guess, the acute phase and into late stages, you can have permanent fibrosis. Acute phase, that can be microabscesses or just inflammation in the myocardium, and the eosinophils may degranulate. That can present as asymptomatic or acute heart failure. Typically, the troponin will precede echo or ECG findings, and it's the most sensitive. Now, if you're not in the acute phase, perhaps that inflammation's died down, but you could have a chronic thrombus. So after that phase, you could have embolic events like we talked about. Um, that can also cause the AV valvular disease, the mitral or tricuspid valves. Then fibrosis will replace the thrombus and try to repair the myocardium. So that can present with restrictive cardiomyopathy, wall thickening, and then also just a continued valvular dysfunction. So that's the classic thoughts, except in EGPA, also coronary artery thrombosis can happen. So that is why people always talk about, do I need to give steroids urgently? And if this is what's going on, basically, if they are having acute heart failure or really acute heart inflammation, um, then you need to give steroids. That's what's going on there. Pulmonary manifestations. Idiopathic acute eosinophilic pneumonia. Basically, this was very common. Well, it was more common in the early days of Iraq and Afghanistan. It turned out that a lot of soldiers just being exposed to either sand or smoke or tobacco, or even dust, would have this reactive eosinophilia sometimes, um, and it would look like this. Usually responded to steroids, and I've obviously never seen any of these, and I understand it's more rare now, but just be on the lookout for that. Chronic eosinophilic pneumonia looks a little different. Instead of having that complete whiteout, this X-ray is known to sort of be the opposite of cardiogenic pulmonary edema. So if you look at the X-ray, there's sort of no cephalization. There's no blending of the casophrenic angle, no A or B lines. Basically, the opacities are in the upper outer lobes. So that's how I remember that. You can still have, you know, just a chronic cough, even with no radiographic findings. And then, of course, you can have the acute eosinophilic pneumonia, which is defined as an eopacity on a X-ray. The, if they're transient or they're transient pulmonary infiltrates. So Loeffler syndrome, as far as I could tell, is basically the eggs will reach the lungs, mature, and then once the parasites hatch, they, I guess, leave and live in the GI tract. And so, but if you have, so you could have mostly a GI parasite, but the eggs might hatch in the lungs. And if you happen to have, you know, if you happen to have a sensitivity to those, then you'll have Loeffler syndrome. If you get actual parasites invading your lungs, then that would be ground-glass opacities, lymphadenopathy. EGPA, we'll talk about that for a bit. It's usually just asthma, but it also could be transient patchy opacities on chest x-ray. Late disease, there's vascular damage and granulomas. I didn't know this for a long time, but when they're saying eosinophilic vasculitis, the way that's determined is, on pathology, there's an eosinophil kind of in the blood vessel wall. So that's how that's defined. Helpful. So Jurgen and Strauss, as far as I can tell, they were not Nazis. So just renaming the syndrome because I guess it's more clear. But they were pathologists. So as pathologists, they saw dead people basically, and they made a criteria and discovered this. The problem with it was that it's sort of the end stage of the disease. So they saw, I think, like 8 or 9 people that had necrotizing vasculitis, small and medium vessels. They also had, well, eosinophil infiltration around the vessels, which is similar, same thing. And then they had these eosinophilic granulomas. So that's great and very specific, but of course you want something kind of more sensitive kind of before the people are dead. So that's what this new criteria was in 1984. And as you can see, they've got the vasculitis still, involvement of organs. I mean, that's fair. So that could be like a granuloma. But they said blood eosinophils or history of asthma. Um, and once again, they're just trying to be more sensitive, obviously less specific, but they're trying to catch it earlier. Now we've got I think the American College of Rheumatology criteria. You just need four of these. And I know there's some new ones, but it's the same thing. We're just trying to catch it even earlier. So extravascular eosinophils, um, eosinophilia, which is 10%, transient pulmonary infiltrates, neuropathy, sinus abnormalities, and asthma. Now, an issue with that is it's actually pretty easy, I think, for a lot of our patients to meet that criteria. All you have to do is have asthma, sinus abnormalities, eosinophils, and neuropathy. You know, so let's talk about really what HES versus EGPA is. A paper from Dr. Corey, and I thought it was useful. It will tell you the dilemma we're in. So they took 270 adults and found that 60 of them met criteria for their study. Basically, they put these people in 4 groups. So biopsy-proven vasculitis, they're on the left. Obviously, they had Church-Strauss syndrome. And then on the right, you've got, they had people with no ACR criteria. So basically, no asthma, no sinusitis, but they were HES. Most of those people were like GI, had GI manifestations, of course. So they were definitely not Church-Strauss. And then you had these 2 groups in the middle where it's sort of like, we can't tell. So the people were obviously one or the other, or they were in the middle. Basically, the people with Churg-Strauss, kind of how we defined it, they obviously had more lung disease, and the people with HES had more GI disease, because that's kind of how they're defined anyway. Looking at all these markers, there's nothing really that stood out. You know, both happen in male and female, and then the CRP is similar across, the ESR is similar across, B12 is similar, even the eosinophil range is, or the eosinophil count is normal. I did see that the highest eosinophil counts are higher in the Churg-Strauss. Special markers, IL-8, eotaxin 1, and unfortunately, for instance, in that upper left with the IL-8, there is a difference between Churg-Strauss and HES, but those two probables or possible Churg-Strauss, uh, you know, the biomarkers don't follow one of the patterns, and they just don't help you distinguish it. And that's how it goes for every biomarker they looked at. Patients with a history of asthma and sinusitis, distinguishing between INCA negative Churg-Strauss syndrome and PDGFR negative HES is difficult because of the overlap in clinical presentation and biomarker profiles. So basically, it's either obvious that it's Churg-Strauss and obvious that it's HES, or you have no idea, right? Um, yeah. So that's my takeaway. And of course, we know that next year their symptoms might be worse. So maybe you could classify them next year, I guess. Um, but just in case you guys want to know if it's HES or EGPA, sometimes it's not worth trying to pin it down because you can't unless it's obvious. So. So kind of in the acute phase, there's tissue damage, maybe necrosis and thrombosis. Long term, that results in repair mechanisms, maybe fibrosis or granulomas, and then there can be long term sequelae. So we also see that in like EOE. You've got the inflammation, and then eventually you get the strictures, which is like from chronic inflammation, and that happened with heart disease. So I just want to show you this pattern of the eosinophil damage. We're on to GI manifestations. We have EOE clinics, so you guys know all about this. I didn't know, but Chiari syndrome is associated with eosinophils, eosinophilic cholangitis. You can have focal hepatic lesions. All right, EOE. I just want to say a little bit about this. We've all seen the New England Journal article that, in kids 8 years old, vomiting is more common versus in adults, food impaction is more common. Super helpful. I want to go over it quick. This is about the time that EOE was kind of reclassified in the GI guidelines. It used to be called PPI responsive esophageal eosinophilia, like PPI re or something. I could never say it right. But anyway, thank goodness now we just call it all EOE. But it was in part based on this study that looked at uh, the 94 EOE related genes and the transcription profiles. So it took some normal people and took GERD people, and then it took EOE based on the older definition, which was, not responsive to PPIs. And they found there were different genes. Then they looked at the people who had EOE that were responsive to PPIs, So before the PPI, sure enough, they looked like, from a genetic standpoint, they looked like EOE. And then after the PPI, sure enough, they kind of normalized a lot of those genes. So I mean, I think we often think the PPI is just block acid, but yeah, they can change the expression of hundreds of genes. But thank goodness for this study, because now we can just call everything EOE. Some is just PPI responsive. Okay, we'll skip this. Manifestations obviously have like a stroke if you have a thromboembolic disease. There is reports of encephalopathy, and as far as I could tell, it's not clear if that's from eosinophil infiltration of the brain or if it's just from microvascular occlusion. And then you can have peripheral neuropathy. Remember, in the Churg-Strauss criteria, there was neuropathy. As far as I could tell, that's typically a numbness, and and if you take a biopsy of those affected neurons, there's actually not eosinophils, and so it's not clear what the mechanism is. Maybe it was a transient occlusion of blood supply as well. But that's what I read. Let me know if there's any new data on that. And, probably we see that all the time. Eosinophils are involved with that. Erythroderma, thickening of the skin. So people talk a lot about eosinophilic fasciitis. Um, Dr. Gata would always talk about like he had a case, I believe, and it was just very thick skin. It felt like wood. Everyone talks about it like it's wood. So dermatographism, urticaria, angioedema, any sorts of nodule or lesions. Um, Causes of HES. I've got it in quotes because it's not always clear what caused what. Amycleon, and basically anything can cause eosinophilia. Atopic disorders, drug hypersensitivity, of course, infection. I want to point out, obviously, helminths, parasites we'll talk about, but also HIV and COVID. You know, COVID can do this. Autoimmune diseases, or maybe you've got an autoimmune disease following viral infection. Then now you have eosinophils. Neoplasia, of course, primary immunodeficiency, or the HES syndrome, which is the myeloproliferative or the lymphocytic variant. Anything can be anything. My wife always makes fun of me for saying that, but that's my final answer. Once I said you can't actually say anything about anything because anything could be anything. And my daughter, she's like 8. She said, "Well, I'm going to say everything about everything." So she's kind of trolling me, I guess. But yeah, I'm the person who will check H. pylori and iron levels on urticaria. Um, that's actually in the European guidelines to check iron levels for chronic urticaria. But there's also, we had a few cases of elevated eosinophil um, and new diagnosis of H. pylori, because we were working them up for their GI symptoms. And we had about 3 cases where the H. pylori uh, was eradicated and their hypereosinophils went away. We thought about writing that up when I was in fellowship, but we talked with I think Dr. Spurkle, and we didn't write it up because he pointed out typically H. pylori is protective against um, HES or eosinophilia, and that's of course because H. pylori is going to cause like a type 1 inflammation. Of course, not everyone's going to do that, and some people will get eosinophils from infection, and so it's not very well described, but a few case reports of H. pylori causing HES out there. The world we live in, and this was an article written in 2007. And if KEP would be in the middle, but I'm sure if you focus on any protein, it'd be like this for every protein. Now you should realize the evaluation is going to be looking at not only the cause, but really the risk of what's involved and what could be involved. The patients might not even know what symptoms they are missing. Dr. Penny's, Dr. Corey, sorry, and I just thought it was a really good article. She calls it high value diagnostic tests. So exposure, medication, symptoms, physically or physical exam, and review of systems, look at all those things we talked about. Troponin, you know why it's there. LFTs, of course. LDH, I thought she was saying just for like a myeloproliferative variant. CT scan. So it's not like the CT scan's going to diagnose the cause per se, but like I said, you're trying to figure out how much involvement there is. So you're going to get a CT scan, and it could be neoplasia that's causing this. I know we didn't say that on the last slide, but you want a CT scan, chest, abdomen, pelvis. I usually get a head just because I want the sinuses anyway, and sometimes they complain of headaches, so you're going to CT scan head to toe, really. Well, head to pelvis. Is it low risk or high risk? And you should know by now it's if it's high risk, it needs steroids, right? And you'll also screen for the schistosomas, the the, um, the parasite. I think I've got it on the next slide. If it's low risk, you can keep doing your evaluation, which might include peripheral smear from tryptase, B12, T cell clonality, genetic molecular testing, T cell immunophenotyping, maybe it's immunodeficiency workup, bone marrow biopsy. Basically, I recommend you find a review article that you like, and just kind of write notes in there. It's sort of the same list, just from a different review article. But what I wanted to point out for the T and B cell receptor studies, basically this is what I get. That's the test code. I'm not sure if anyone gets other things, but this will tell you if there's a T cell clone. Like basically if there's a T cell single clone that's kind of highly highly prevalent. So actually, this can be positive with infections sometimes too. So, but if it's normal, I definitely just am reassured. If it's not, I'd send them to Hemonc. But I feel like I need to do everything on this list. Okay. says do a bone marrow examination on all patients with elevated tryptase or B12 levels, but also do the bone marrow biopsy for AEC of 5,000. So when I was in fellowship, I never saw this because this is a newer article, but now it's nice that there's a cutoff of 5,000 for the bone marrow biopsy. I definitely sent a lot of people for bone marrow biopsy with lower eosinophil counts. But, let's see. I also get the H. pylori, sometimes AM cortisol, EBV viral load is on there. ANCAs, I don't know why it wasn't on there, but I usually get it because these people usually have asthma and sinus disease. I think I've only ever had one be positive. Strongyloides is the parasite. Basically, if you need to give emergent steroids, what you would do is you could empirically give ivermectin, and actually, Amy actually puts the dose in her paper just so, in case you need to, and says additional testing should be based on the clinical history. So let's talk about that. You've sent people to infectious disease to ask if they have a parasite, and infectious disease basically didn't do anything and said no, they don't have a parasite. Um, Immigrants or refugees, and it tends to be people who are born outside the U.S. that tend to have HES. At least that's what I saw in Fort Campbell, a lot of. But people from outside the U.S. can have subtle or no symptoms, or even mild eosinophilia, and also if they have chronic infections. A lot of the literature is based on acute symptoms of Caucasians traveling and getting these infections. Having said that, so it's not like you can just give someone an antiparasitic and you're gonna, maybe wipe out half the parasites. There's no such thing as like a broad spectrum antiparasite drug. And then also you got to consider for most parasites, actually there's not any tests available. So you're really kind of, you're kind of stuck. And the O&P is not sensitive. But now you can understand why infectious disease almost does nothing all the time when maybe they should, based on that you can have subtle symptoms. Okay. Oh yeah, and some parasites can cause a positive ANCA. So even if you have a positive ANCA, you can't say it's not a parasite. So here's what I do, especially because I know ID is not going to do anything. What I do is I just ask the people every country they've ever been to. And, they say a bunch of countries. Then I just put those into Travax, um, and it will have a list of parasites. And then I log into LabCorp and search for every test I search for each of those parasites. And if there's a test, I order it. On top of that, I get an ID consult. Um, I have a low profile for getting a head CT or a low threshold, but if there's more than that, or it's like a severe headache, I'll put in a neuroconsult. I won't actually order an MRI. So I've had 3 or 4 patients that came back with elevated schistosomiasis antibodies, and some of them I treated with infectious disease advice. But basically, my caveat there is you're supposed to give praziquantel once is what you can do, um, but then you should give it 1 week later. And actually, if they're having symptoms, it means it's working because it's killing off the parasites. The reason you're supposed to give it 1 week later is so that it can kill the parasites that are in a dormant stage initially. I recommend doing the two-part regimen, so like the dose now and dose in 1 week, even though there's like a 90% cure rate with just the one dose. That's because, you know, a lot of these patients that I had, they weren't feeling, instantly better. So I was kicking myself for not just giving them two regimens, like two doses 1 week apart. So I could be 99% sure it worked. Um, I also had a positive cyclospora. Um, I was able to get that from a GI stool PCR, and then somehow it was an infant that actually had a interaggregative E. coli positive in the GI stool PCR. I think his eosinophils were like 5,000. It was like a 11-month-old. So, and it resolved with just azithromycin. Yeah, that was nice. And his GI symptoms did too, but not his eczema, unfortunately. He was 41,000. Uh, it went down to like 10,000 after the single dose of azithromycin. So, you know, basically with the parasites, you have to do what you can feel comfortable with and live with. So after a while, I just couldn't keep sending people to infectious disease and having them waste like 2 months to even get in, and then get told they didn't have anything, and then they see me 3 or 4 months later. I just couldn't keep doing that. I was just kind of beating my head against the wall. I felt like so that's the approach I took, and I felt good about it. Yeah, so altogether, I treated maybe 6 people for parasites or that E. coli. I think only 3 of them got better. Uh, for whatever reason, the other 3 didn't. It's not like it was 100%, and it wasn't even very many patients. So, all right, this is kind of a table you can go through. We've already just talked about the diagnostics. Apparently, there's this familial HES, which uh, even Amy Cleon said she only had like 11 patients, so that's super rare. And she's always looking for more, she says. Um, is it secondary to some other condition? We've kind of talked about that. Now, if it's, is it neoplastic? That's why we did a CT. Finally, if it's not, then you can call it idiopathic HES. Some treatments and some criteria, some definitions. The neoplastic, they can get Gleevec, just so you guys are aware that that one is kind of a different treatment than the others. Um, and then for the lymphoid variant or the lymphocytic variant, basically they have a high risk of lymphoma. I wanted to point that out, so that's why that matters. Because you're going to treat them the same, with maybe Nucala or something, or a biologic, but that's different about them is that surveillance. All right, we get to management chart. As you can tell, it's like all the same things are in all the boxes. So we've got steroids in every box. We've got like immunosuppressives in every box. Well, I guess we don't have interferon in every box. It's in the top there. But biologics in every box. It's sort of basically what you want to give them. I do have an opinion on Nucala for EGPA, which is that the Fasenra, is anti-IL-5 receptor, and that actually causes, as you've probably heard, death of the eosinophil. So my opinion is, if you think it's Church Strauss but you're not totally sure, I would almost try Fasenra first, because that's going to cause the the peripheral eosinophils, meaning the tissue residing eosinophils, to be zero. The mepolizumab will cause the blood level to be zero, but actually the tissue residing eosinophils will not be zero. So I know it's FDA approved for mepolizumab, but that's because it's been out longer than Fasenra, in my opinion. So I like Fasenra a lot more than mepolizumab. And obviously, dupilumab is better than all of them. You guys like that lecture okay? Let me know if this was even a good format. And basically, eosinophils are involved in many conditions, keep a huge differential diagnosis. Um, it's defined as 1500 in the absence of known causes. Any organ can be affected. Um, Presentation can be emergent. So yeah, that's the main thing. Is this cancer and is it emergent? And I assume there'll be guidelines soon. I really do think there will be. Maybe there are.